Good afternoon, everyone, and welcome to Grand Rounds. Today, it's my pleasure to introduce Dr. Gopala Koneru. Dr. Koneru is an internist, and he also is a transplant hepatologist. He currently is a clinical assistant professor of transplant hepatology at the University of Iowa, and he has very kindly accepted our invitation today to provide us with a review of fatty liver. And please join me in welcoming Dr. Koneru.
Good afternoon, everyone, and I want to thank you for having me for your Grand Rounds. So when I was thinking about this topic, I thought about what would best help you guys. And fatty liver is an epidemic, and it's the most common thing I see in my clinic as well. And it's probably what you're likely going to see or come across. So I thought this would be beneficial. So what is fatty liver, otherwise known as hepatic steatosis? And steatosis is just accumulation of fat or triglycerides in the hepatocytes, and they get swollen with fat, and there's, on the biopsies you can see globules of fat. Fat doesn't necessarily mean there's going to be inflammation, but when there is inflammation, we call it steatohepatitis, and that may be caused by direct cellular cytotoxicity of the free fatty acids, oxidative stress, lipid peroxidation, and other mechanisms. So broadly, we can classify it into microvesicular and macrovesicular based on biopsy. All this means is, macrovesicular means the globules of fat are very big, microvesicular, they're small. So some of the causes of this, microvesicular array syndrome, acute fatty liver pregnancy, HELLP syndrome, certain medications like valproate and antiretrovirals. And macrovesicular, which is the more common type, would include metabolic syndrome, such as obesity, diabetes, hypertension, hyperlipidemia, excessive alcohol use, hepatitis C, Wilson's, and medications as well. Focus on the two most common things, which is alcohol and what we call non-alcoholic fatty liver disease. So these are the most common causes in the U.S., and they are contributing to the rising incidence of hepatocellular carcinoma. Especially with hepatitis C, we have really good treatment for those now. The incidence of that is coming down, and HCC or hepatocellular carcinoma related to hepatitis C is coming down, and actually hepatocellular carcinoma related to non-alcoholic fatty liver disease has overtaken that. So some of the objectives overall for this talk are basically identifying risk factors for the development of fatty liver disease, identifying patients at risk, describing determinants of progression and its complications, providing guidance on optimal management strategies, and evaluating current and emerging pharmacological and non-pharmacologic strategies for treatment of fatty liver disease due to alcohol and metabolic syndrome. So the first one I wanted to talk about is NAFLD, or NASH. So NAFLD just stands for non-alcoholic fatty liver disease. And it's a diagnosis of exclusion based on the following criteria. There's evidence of hepatic steatosis based on serum biomarkers like aminotransferases, imaging such as ultrasound or CTs or MRIs, or histology if there happens to be a biopsy. No, this is important, and no excessive alcohol consumption, which we, for example, say less than 20 grams of alcohol for women and 30 grams of alcohol for men. So one standard drink would have 14 grams of alcohol, which is a 12-ounce beer or a 5-ounce wine or 1.5 ounces of hard liquor. And the other important thing is not having any other secondary causes of hepatic steatosis, such as hepatitis C or medications, and as mentioned in the previous slides. So NAFLD is kind of the umbrella term of fatty liver disease not due to alcohol. So it includes non-alcohol fatty liver disease, which is defined as greater than 5% of hepatic steatosis on biopsy without evidence of hepatocellular injury. And the risk of progression is very low. Then the next one would be NASH, or non-alcoholic steatohepatitis, which basically means there's fat and inflammation. And so it's defined as greater than 5% of hepatic steatosis and hepatocellular injury with hepatocyte ballooning and inflammation. There might be some fibrosis as well. So the next one would be NASH cirrhosis, which basically means there's evidence of bridging fibrosis and would classify it as cirrhosis. So I would like to say that between these three, people can fluctuate. They can, depending on what they're doing, they can have steatosis and then have steatohepatitis and then go back to steatosis and even normal liver. Once they have fibrosis, usually the fibrosis stays if they have cirrhosis, but they can have a little bit of reversal, and can improve. But once it's there, it's difficult to treat. I wanted to see if you guys have heard about MAFLD, which is a new terminology that hepatologists have been trying to essentially rename NAFLD as MAFLD. So MAFLD stands for metabolic dysfunction associated fatty liver disease. And basically, we're trying to rename NAFLD because we want to, one, understand that fatty liver can be due to alcohol and metabolic syndrome, and it can be a spectrum. Doesn't necessarily mean one or the other. People can have fatty liver due to, can be drinking, and they can have risk factors for metabolic syndrome. And we wanted to take the alcohol portion of the NAFLD out of the name. So an international consensus, expert consensus statement has tried to delineate a definition. This is still not 100% adopted or accepted yet, but the proposed diagnostic criteria is like previously hepatic steatosis based on serum markers, imaging, or histology, and at least one of the following metabolic criteria: obesity, type 2 diabetes, and signs of metabolic dysregulation, which means at least two of the following factors. So central obesity, hypertension, hyperlipidemia, LDL levels, or HDL levels, impaired glucose fasting, and there's a calculator called HOMA-IR as well. So this new definition may be more functional than NAFLD definition and improving identification of patients at high risk for disease progression. So what's the scope of the problem? There are 60 to 80 million people, we estimate, in America that have some sort of fatty liver due to obesity. Out of those, 15 to 20 million may have NASH, detected or undetected. And we can see the usual pathway, about 20 to 30% over 3 years, or they can progress to have some sort of fibrosis. And those patients can progress to having cirrhosis, about 1 to 2 million. At any point, they can progress to liver failure, which would require liver transplantation. But I want to focus also on that people without fibrosis or minimal fibrosis can progress to hepatocellular carcinoma, which I will cover in later slides. So again, the risk factors, we've kind of mentioned it in the definitions. Some of the common ones are obesity, diabetes, hyperlipidemia, polycystic ovarian syndrome, and the metabolic syndrome, which we already mentioned. in this definition, we'd say 3 or more of the following features of waist circumference, triglycerides, cholesterol levels, and blood pressure. Some of the other conditions you can think about that may be contributing or causing metabolic syndrome or risk factors for NAFLD is hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, and other risk factors include non-modifiable risk factors, include age, so elderly, and sex, the males greater than females, and certain ethnicities, such as Hispanic, non-Hispanic Caucasians from Northeast European countries, Middle Eastern, or Asian populations, such as from the Indian subcontinent, are high risk for fatty liver. So what are the AASLD guidelines? So AASLD is the American Society of Liver Disease, study of liver disease. And they have guidance, they have guidelines for most liver diseases, and you can actually, it's readily accessible for free on their website. So if there's ever any questions on what you should do, you can always look it up. But what do they recommend in terms of screening? So routine screening for NAFLD in high-risk groups in primary care has not been recommended because of uncertainties surrounding diagnostic tests, treatment options, lack of knowledge of long-term benefits, and essentially cost-effectiveness of screening. But they did say if there's a high index of suspicion for NASH or NAFLD in patients with type 2 diabetes, can do clinical decision aids such as NAFLD fibrosis score or fibrosis 4 score or FIB4, or FibroScan, otherwise known as vibration-controlled transient elastography, can be used to screen patients for fibrosis or risk for progression. So basically, if they have high risk factors, you can do some screening, which I will get into in later slides. So this is a common dilemma that that primary care physicians have, mentioned to me. You do routine labs and you find some mild aminotransferases, such as usually ALT a little bit higher than AST, up to 2 to 3 times upper limit of normal, which, upper limit of normal is 35. So it can be anywhere from, up to 100, 150. Or they had some other workup and they incidentally was found to have hepatic steatosis on an ultrasound or some sort of imaging. So what do you do? So you need to ask yourself, do they have risk factors for NAFLD or NASH? Do they have high BMI, diabetes, age greater than 50, family history? Second, are they drinking alcohol, a significant amount of alcohol? And, we can talk about how to screen for that in later slides as well. And do they have other causes of hepatic steatosis, like medications or hepatitis C? And the last question is there fibrosis? And how do we check for that? So as mentioned, there are non-invasive biomarkers, or this is essentially calculators to check for level of fibrosis. The first one is FIB4, and this is essentially the formula and how it looks, and you can Google it and you'll get the calculator. Essentially, you enter the age, AST, platelet count, and ALT, and it'll spit out a number. If the number is less than 1.45, it has a negative predictive value of 90% for advanced fibrosis. And if the score is greater than 3.25, it has a 97 specificity and positive predictive value of 65% for advanced fibrosis. So this is the other score, NAFLD score, or NFS, and it has a few more things that you can enter in, and essentially it'll also spit out a number. So if it's very low, it's less likely to have fibrosis, or very high, and it's likely to have fibrosis, and then in between is kind of an indeterminate score. So that's the problem with these calculators is that they're very good with predicting low probability or high probability of fibrosis based on the scores. But in the middle, there can be a gap. But this can be overcome with sequential combination of these scores. So if you can use one FIB4 and then NAFLD, and then if there's some consideration for fibrosis, you can go and do a FibroScan. So how are these scores in terms of long-term correlation? So there was a study that showed the hazard ratio for transplantation death over a long period of time. And you can see the scores kind of correspond with survival probability over a long period of time. So based on their risk factors, that you can see that it does correlate. So what I generally would say is calculate the FIB4 or NAFLD score. If they're low risk, they can be managed in the primary care setting, and you can repeat the scores in a year. If they're intermediate risk, you can think about referring to GI or hepatology, or you can do a secondary assessment of FibroScan and see if what the degree of fibrosis is, if it corresponds with the calculator. And if they're very high, if the score is very high, you should refer to a hepatologist, or if no hepatologist available, maybe GI. So what are the other kind of warning signs for maybe referral, or just warning signs that you should think about in terms of advanced fibrosis? So when you have advanced fibrosis or cirrhosis, there is portal hypertension that develops, and also there's impaired synthetic function of the liver itself. So the things that we look for are low platelets, which that's kind of our poor man's biopsy. So essentially, if they have platelets less than 150, it correlates with splenomegaly and development of portal hypertension. So the lower the platelets, the higher the suspicion of the degree of cirrhosis. If they have higher INR or low albumin, it shows impaired synthetic function. And other signs of portal hypertension includes ascites or varices. And other signs of hepatic decompensations include hepatic encephalopathy or variceal or GI bleeds. So these would be warning signs to either admit the patient or refer the patient to a hepatologist or a transplant center. So what's the role of liver biopsy in NAFLD or NASH? So in general, we don't usually like to do it unless the diagnosis is in question. If there's other coexisting chronic liver diseases, or we can't exclude other things, so this would give us the definitive diagnosis. So the report would usually include the classification, is it steatosis or steatohepatitis, the severity, and they have scoring systems such as NAS or SAF, and they would give us a degree, and they would also tell us the degree of fibrosis as well, and the absence of other etiologies. So once you've risk stratified them with the fibrosis scores, this can help you in management as well. So if they're low risk and their FIB is low, or the biopsy shows low F1 or F0 fibrosis, this can be managed in the primary care setting with lifestyle management, and they don't really need pharmacotherapy for NASH at this point. And in all of these, you would do risk reduction for cardiovascular and care for diabetes, but in the higher settings, we have some preferences. So what's lifestyle management? What do you tell your patients? It would include a combo of dietary changes, structure, exercise, and weight loss. So, calories in, calories out. They should have a deficit of calories to lose weight. these are three societies for liver. This is for the U.S. EASL is European the association, and APASL is the Asian Pacific study of liver diseases. So that's the Asian Society, and they all essentially recommend the same things. And in certain patients, bariatric surgeries can be recommended as well. But the main thing I tell my patients is to lose 5 to 10% of their body weight over a year. Any amount of weight loss is helpful. So in terms of medications, these are the society recommendations from 2018. Essentially, if they have NASH, we would recommend vitamin E and pioglitazone, although there's a difference between the societies in terms of with and without diabetes, where the ASLD does recommend with and without, whereas others don't recommend with. Statins, I do want to mention, are not recommended specifically for NASH, but they should be used for treatment of hyperlipidemia and decreasing cardiovascular risk. And they're safe to be used in NASH. So you should not take patients off their statins if they have a little bit of enzyme inflammation, enzyme elevation. Ursodiol is not recommended at this time. Omega-3, similar like statins, not recommended specifically for NASH, but can be given to treat hypertriglyceridemia. Obeticholic acid is being studied, but not been validated yet. And these two medications in 2018 were still being studied and currently are. And in terms of metformin, this was not specifically recommended by any of these societies for NASH specifically. But studies have shown that metformin can decrease the risk of HCC and can improve HCC survival. So again, medications specifically for NASH, there's actually none that are technically FDA approved. They're all off-label. And there's evidence for vitamin E on a review of meta-analyses in 15 randomized controlled studies that showed vitamin E of 400 to 800 units daily can be beneficial, especially in patients with these risk factors. But you should take caution that the study, when using 800 international units, did show increased CV mortality, hemorrhagic stroke, and prostate cancer. So if patients have CV risk factors, or elderly males, I do use that with caution. Pioglitazone also has been shown to be helpful in the PIVN trial, which, again, did vitamin E versus pioglitazone versus placebo, and the primary outcome was on biopsy 2-point improvement of the NAS score of fibrosis. And it is recommended in patients with diabetes. Some of the side effects include weight gain, fluid retention, possible risk of bladder cancer, and osteoporosis. So what about GLP-1 and SGLT2 medications? Basically, they've shown benefits. They've not made it into the guidelines yet, but if you have an excuse to use these medications, I would recommend using them. What about bariatric surgery? In general, in selected patients who are unable to lose weight on their own with serious comorbidities and are at risk of progression and complications, bariatric surgery can be considered. And studies have shown improvement in NASH and even in some in fibrosis. So there can be some reversal of fibrosis after 5 years after surgery, more so when they're F1 or F2. And this graph just shows the more weight they lost due to bariatric surgery, the better the NASH resolution. So this is kind of the treatment algorithm. So mainly weight loss, with lifestyle modifications, and treat diabetes and cardiovascular risk factors with metformin and statins and diabetes medications. And in people with NASH, with some fibrosis, definitely would consider vitamin E and pioglitazone in patients with diabetes. So in terms of HCC in NASH, as I mentioned, people can progress the usual route of cirrhosis in the HCC, but there is a portion of patients, up to 2.8%, that can go directly to HCC over a 20-year period. So as you can see, that can be, with the U.S. population, it can be a very high number. And incidence of NAFLD-related HCC has been on an increase at 9% at an annual rate. And around 13% of HCC reported from the study of patients from veterinary VA did not have cirrhosis. So that's also significant. This is just kind of a diagram on the pathogenesis and prevention of NAFLD-related HCC. Basically, all you need to know is it's multifactorial. Microbiomes involved, chronic inflammation, and things like that. I don't want to get too in detail due to the time limits right now. So the next thing is, do we do surveillance? In cirrhosis, absolutely, that's recommended every 6 months with ultrasound and AFP. Sensitivity is a little bit better when used with AFP. What about without cirrhosis, people with NASH and NAFLD? Looking at the guidelines from the different societies, generally there wasn't really recommended, but in the EASL recommendations for 2018, in patients, according to the PAGE B score, which was basically a calculator that showed platelets, age, gender, hepatitis B, or patients with F3 fibrosis, we can screen, or we would consider to screen. So I would recommend patients who have F3 fibrosis on biopsy or a scoring system or FibroScan, who are males, greater than 65 years, type 2 diabetes, possibly could screen with ultrasounds for development of HCC. So again, in summary, for NAFLD-NASH, identify the patients at risk. If NASH, risk stratify them with biomarkers with FIB4 or NAFLD score, and FibroScan if needed, and refer if needed if they have high fibrosis, and treat according to the risk stratification and monitor for HCC. So the next huge topic I would say is alcohol-associated liver disease. So the first thing I want to mention is there's a change in terminology. We don't use the term alcoholic anymore. We use alcohol or alcohol abuse. We refer to it as alcohol use disorder or alcohol-associated liver disease, or if they have inflammation, alcohol-associated steatohepatitis or alcohol-associated cirrhosis. So we all know alcohol is a big problem, and it's the oldest known form of liver injury and major cause of liver disease worldwide. Alcohol liver disease in the U.S. about 2% in the general population, and mortality in the U.S. is about 5.5 to 100 per 100,000. Worldwide, 50% of deaths due to liver disease related to alcohol. And prevalence of alcohol liver disease is on the rise. On a survey between 2001 to 2013, there's an increase, 50% increase in alcohol use disorder. And this may be due to increase in alcohol use in women, older population, and different ethnicities as well. So alcohol use disorder. Basically, the DSM-5 combined alcohol abuse and alcohol dependence into a single disorder called alcohol use disorder, which can be classified into mild, moderate, and severe based on this criteria. There's a scoring system. And alcohol use disorder basically is a chronic relapsing brain disease characterized by impaired ability to stop or control alcohol use despite adverse social, occupational, or health consequences. And this is just the definition for binge drinking, which can also be a risk factor. Basically, greater than 5 standard drinks or in males, or 4 standard drinks in females over a 2-hour period, or even in a day, depending on which society. Or heavy alcohol use can be defined as greater than 14 drinks per week per male and 7 drinks per female. So screening for alcohol use disorder. The important thing to do is be non-judgmental. And an easy way, first question you can ask is, how many times in the past year have you had more than 5 drinks in a day, or 4 drinks in a day for women? The other questionnaire I would suggest is the audit. And you can start with the audit C, which is just these first 2 questions. And that could assign a score, which would then trigger the full audit inventory. Audit C is better than CAGE, and score greater than 4 to 5 may indicate harmful alcohol use, but it in itself does not provide the diagnosis for alcohol use disorder. For that, you would have to use the previous questions that I showed here. I do want to talk briefly about biomarkers of alcohol use. This is something that I use in my clinic. Ethylene glucuronide and phosphatidyldiethanol. Honestly, I use the short forms because they're difficult to pronounce. So ETG or PET. So these are just tests to see if patients are drinking over a prolonged period of time. I use primarily PET, as ETG can have false positives and difficult to interpret with renal failure. But PETs have a half-life of 10 to 14 days. And this is basically a phospholipid only made in the metabolism of alcohol use. So we can really tell if patients have been drinking in the last 4 to 6 weeks. All patients would be screened routinely for alcohol use using validated questionnaires such as Audit C. Alcohol biomarkers can be used to aid the diagnosis and support recovery, but it is not used to, it can be used as a catalyst for discussion, but should not be used as a tool to catch or punish patients. Treatment of alcohol use disorder, and I'm going to say this multiple times, abstinence. Abstinence is the absolute most important thing. Patients with severe, moderate to severe, or clinical evidence of alcohol liver disease should be referred to an alcohol or addiction specialist. When they're very sick, it's helpful to have a multidisciplinary integrated treatment for this, as the relapse rate is very high for these patients. Over the course of a year, relapse rate ranges from 67 to 81%, which is very, very high. So AASLD, again, recommends referral to specialists for addiction. And again, there is a limited data for the use of acamprosate or baclofen for alcohol use disorder. The other medications are a little bit more difficult to use when they're actively drinking. I did want to speak about the disease spectrum. I'm sure you guys remember this from pathology, but basically this is the spectrum of liver disease, and it can normal liver to steatosis. And this can happen in any of us when we drink more than 60 grams of alcohol daily for 2 weeks. And it can reverse after 4 to 6 weeks of abstinence. It is important to see that steatosis can develop, if they continue to drink, can develop the steatohepatitis, which over time would cause fibrosis. But sometimes if they're drinking a lot and they have alcohol-related hepatitis, they can acutely decompensate with portal hypertension and other things. But it's also important to know that this is a spectrum. It's not, they can have steatohepatitis, some fibrosis, some decompensation. It's a spectrum of disease. Some risk factors, obviously if they have risk factors for NAFLD, other hepatitis B, C, other things, certain non-hematophile risk factors as well, can predispose to alcohol liver disease. So the pathophysiology is not really well understood and it's very complex, but several factors can contribute. Heavy alcohol use resulting in fat accumulation, the toxic metabolites produced from alcohol, which is acetaldehyde and acetate, the gut permeability causing inflammation and change in gut microbiome, and direct oxidative stress from these, as well as cytokines, leading to an inflammatory cascade. So, the presentation of alcohol liver disease is very varied. It can be nonspecific, just patients feeling fatigued and having weight loss or some mild right upper quadrant pain, to as severe as progressive jaundice and signs of portal hypertension with ascites and variceal bleeding. And imaging can be nonspecific sometimes as well. I would recommend, if we're suspecting liver disease, to do an ultrasound to exclude any obstructive pathology. And if needed, a CT or MRI triple phase, which is a liver scan, if they need to be screened for liver cancer. And alcohol-associated steatosis, again, you can have elevation of AST greater than ALT from 1.5 to 2 times upper limit of normal, some alk phos elevation. But basically, they have fat in the liver, which causes inflammation. And this is reversible with lifestyle modifications and abstinence from alcohol. Alcohol-associated cirrhosis, usually these patients, as you guys have seen, sometimes inpatient, they present for the first time decompensated and they didn't know they had cirrhosis before, or slowly they progressed over years. And imaging will show liver nodularity and they have signs of portal hypertension. You can do a FibroScan as well if you're unsure to show the level of fibrosis. And again, no amount of alcohol is okay for these patients. So I want to talk a little bit more in detail related to alcohol-related hepatitis, which you can see in the primary care setting or in inpatient. So this is a clinical syndrome with rapid onset of jaundice with elevated AST, ALT. And the NIH-sponsored consensus meeting of investigators, it was proposed to define it as jaundice within the past 8 weeks, starting the past weeks, ongoing alcohol consumption for greater than 6 months of moderate use with abstinence less than 60 days. So I tell patients or other providers this, that, even if they quit 4 or 5 weeks ago, even 6 weeks ago, they can still develop alcoholic hepatitis due to the inflammatory cascade that happens afterwards. As mentioned, they typically have AST-ALT ratio 1.5 or greater, but I should note that their values will not be greater than 400. If it's greater than 400, they either have another etiology or multiple etiologies, and serum bili of greater than 3 as related to alcohol hepatitis. So what about liver biopsy? Do we need to do liver biopsy in these patients? Typically not. Basically, you can use this criteria from previous to see if they have possible alcohol-related hepatitis or probable. If they do, I wouldn't recommend biopsy, but if there's some sort of confounding factors, such as ischemic hepatitis or possible drug-induced liver injury, or the pattern of the liver enzymes and labs aren't fitting, then we could consider it. In the histology, it's pretty straightforward. It's very difficult to delineate between NAFL or NASH versus alcohol, but they both have ballooning degeneration, but Mallory-Dank bodies or Mallory-Weiss bodies are seen in alcohol as well as this chicken wire. So that can help sometimes. So this would be a Mallory-Dank body right there. Prognostic scores in alcoholic hepatitis can be used to the severity and short-term prognosis, but alcohol abstinence is the main thing. So MADRS discriminant function is the first prognostic score. That's one of the older ones, but this is the formula. Basically, if they have a score greater than 32, they have a high risk for mortality. And we use this as a cutoff for glucocorticoid treatment. So if you suspect alcohol hepatitis, you would do this score. And if it's greater than 32, you would consider doing steroids if they are not infected. The other score that's been recently developed, or relatively recently compared to MADRS, is MELD. It's not been used for starting steroids, but it has been proposed if a MELD is greater than 20 to be used. And these are other prognostic scores. This is age, bilirubin, INR creatinine. This is Glasgow alcoholic hepatitis score. And this is a allele score, which I'm going to talk a little bit more in detail. But basically, once you realize the score is greater than 32 from MADRS and initiate corticosteroids, typically 40 milligrams of prednisone or equivalent, you need to see if that's helping. So the allele score was developed to see if it's helping, and there's a calculator which I'll show. If the number is greater than 0.45, it means that they're not responding, and the risks outweigh the benefits of continued steroid use, so you stop at day 7. And if it's less than 0.45, you continue for the full course of 28 days. So these are studies that basically shows that the allele score has been validated, and it predicts 6-month mortality in patients treated with steroids. And as I mentioned, can be used to assess response. And you can see the survival probability between 0.45 and greater than 0.45, non-responders versus responders. And I do want to mention that there's been a study that has shown that allele score calculated on day 4 is almost as good as day 7. So if you have patients that are inpatient and you've already started steroids, you can just calculate it on day 4 and see if you need to continue or not. So this is what the calculator looks like. You can go to allelemodel.com, just enter it, and it'll spit out the numbers. So the major thing you need to know is you need to have a bilirubin, creatinine, albumin, and PT is the main thing, PT and bilirubin on day 0. And then you need to have the bilirubin from day 7 to calculate the score. In terms of moderate alcohol-related hepatitis, is essentially defined as MELD less than 20 or MDF less than 32. There's no specific treatment for this other than abstinence. So again, AASLD recommendations. Lab-based prognostic scores should be used to determine prognosis of alcoholic hepatitis. So certain patients will ask, what's the percentage of mortality and things like that? And the MELD score, if you calculate it, it'll spit out a score and mortality rate for 30 days, 3 months, 1 year. So you can tell patients that. And we talked about the use of steroids in these patients. So again, abstinence is the main thing. And continued alcohol use in this setting, the patients can acutely worsen with variceal bleed, worsening ascites, hepatic encephalopathy, and possibly death. Nutritional therapy is very important in these patients. There's significant malnutrition in patients with liver disease, and especially alcohol-related liver disease. Meta-analysis of nutritional support and alcoholic hepatitis suggests improvement in hepatic encephalopathy and fewer infections. Meta-analysis of specific nutrients showed no benefit. Zinc can be considered, and I do use it occasionally. And low-calorie intake has associated with higher mortality. Again, coming to corticosteroids, it's been validated. And the main validation was the STOP-AH trial or STOPA trial. And that showed prednisolone versus no prednisolone, pentoxifine versus no pentoxifine, and 1-year survival in all these groups. So it is important to know that prednisolone versus no prednisolone, there was a significant decreased reduction in 30-day mortality, but no reduction in long-term mortality. Pentoxifylline has not been shown to be beneficial and has not been shown any survival benefit in alone or with combination of corticosteroids. It has been shown to be beneficial with HRS or hepatorenal syndrome. In terms of glucocorticosteroids plus NAC, can be used in severe alcoholic hepatitis, NAC and acetylcysteine. So if the patient's admitted and they're very sick, you can start NAC and corticosteroids. Again, talking about pentoxifylline, it's been failed to confirm survival benefit and has shown reduction in development of HRS. So the treatment algorithm for alcoholic hepatitis is to, again, assess for contraindication for treatment, uncontrolled infection, that's one. AKI with greater than 2.5 creatinine, uncontrolled GI bleed, other diseases that could be contributing, or shock or multi-organ failure. If they're eligible, then we talk about prednisolone or prednisone with or without N-acetylcysteine and nutritional support. Calculate the Lille score at day 7 or day 4 and assess for response. Again, this just summarizes, this is the AASLD recommendations, which just summarizes what I just said. And I do want to talk about liver transplantation in alcohol liver disease or acute and severe alcohol-related hepatitis. So previously in liver transplant centers, there was an arbitrary 6-month rule to allow for liver recovery and demonstrate commitment for abstinence, but that's no longer the case. As patients with severe alcoholic hepatitis not responding to medical therapy have mortality rates as high as 70% for 6 months, so they might not survive this long. Sometimes we do consider 3 months, but I think what I want to mention is that it should be done on a case-to-case basis. So if they're not improving and their MELD score is very high, above in the 30s, although they drank alcohol recently, they may be a candidate for liver transplant based on their social support and whether or not they drank and continued to drink despite knowing they had liver disease before, and things like that. So patients with decompensated cirrhosis, child Pew score C or MELD score greater than 21 should be referred to a liver transplant center. And again, candidates are done on a case-to-case basis, not on a fixed interval of abstinence. So in summary, for alcohol liver disease, history is essential for diagnosis. Alcohol hepatitis in acute presentation or alcohol liver disease is an acute presentation. So when they have severe alcohol hepatitis with MADRS and MELD score, there is a high chance of mortality. Abstinence, nutrition, steroid plus NEC can be beneficial. And what I mentioned about the legal score, calculating on day 7, and whether you should continue or stop. And the 6-month rule of abstinence is controversial and arbitrary. And liver transplantation is effective for treatment of severe alcohol related hepatitis or alcohol liver disease in selected patients. So I just wanted to open up for any questions. And also, I did want to leave the number for my clinic if there's any possibility of patients being referred. If any questions, you can email me or call me to discuss. So I'll just, you can unmute, or if you want to type in the chat box, I'm happy to answer any questions. Does green tea cause toxic hepatitis? So there are certain herbal remedies and herbal teas that can cause toxic hepatitis. Hepatitis is inflammation of the liver. What we call it, we classify that as drug-induced liver injury. So it can, and I do use it as a screening question. If it can confound factors if they have risk factors, if they're drinking, or if they have risk factors for NASH. So it can definitely confound things. So it can have an additive effect sometimes. When people are drinking mild to moderate amount, they're obese and they have risk factors for NASH, and they're taking herbal supplements and maybe even Tylenol, and they can present with severe hepatitis. So it can happen. So this is something that I do ask my patients if they're taking any kind of herbal supplements or herbal teas. Any other questions? Okay, well, thank you everyone for having me. And I can leave my personal number in the chat if anybody wants to contact me for any patients they want to discuss. And please don't hesitate to reach out for any reason, okay?
All right, thank you for presenting today.
Yeah, no problem. Thank you for having me.